none of these is wrong. So for the self-made guide, what we see often is patients will walk in with their guide in hand, they'll pop it in their mouth, and we'll take a scan. And then we'll look right where the guide is placed and we'll measure it. We're at 5 millimeters there, 5 millimeters to get to it, and another 9 sitting there at this angle. If this looks like it's tilted a little too facially, which I believe it probably is, you can put that back in hot water and tilt it back. So you can angle it. You can adjust your own guide. And the patient comes back and we take another look and see if it's better. It's one way to do it. And if you're in a tough area, if the patient's price conscious, there's a lot of reasons why people do this, and I can't fault them. They're trying their best and they're doing good work. So that's the self-made guide. Here's the lab-made guide. Self-made, lab-made, self-made, lab-made. I changed the word. I'm actually really good friends with a couple labs, and I respect the labs that don't make guides unless it's computer made. And the reason I've got a big issue with lab-made guides for this reason. I can pretty easily understand this process. This makes sense to me. Right? We've got some polyvinyl, and we create a stone model. I understand how that happens. It's not rocket science, so I can get that. I don't know how this thing comes into play. Looking at a piece of stone, how do you know where the bone is? You can't even separate ginger from bone.
Exactly, I agree.
Yeah. I mean, and then who's doing it? It's not a doctor. If you go into a mega lab, do you even know who's doing it? You know, I mean, I'm all for giving the 16-year-olds some after-school work, but come on. I mean, this kind of worries me a little bit. And you get stuff like this, where you're just not quite where you need it to be because you couldn't see what was going on in that stone model. So that's Steve.
Marshall, what that type of surgical guide shows you is where you want it from a restorative point of view versus the surgical point of view.
I totally agree. And labs know this, and they're the restorative gurus. We actually work with a couple labs to create our guides, but they do it with computers. And the reason is, if I were a doctor, I would actually feel a little bit nervous saying, hey, you plan this out for me, to another doctor, for the surgery part. But I get that, it makes sense.
Marshall, I don't mean to break up your concentration, but there's this one story that I have to have Chris tell. We'll just take 1 minute about a lab that Accurate Eye Lab. We won't mention the lab, but what was the response when you asked them how they made that?
Yeah, they told me, well, I use my Accurate Eye. Basically the Johnson lab asked them to help us by having this pre-made without us even evaluating the patient, which was their intention as well. But again, as Marshall said, very, very important. If we just go back one slide, please.
Sure.
So it absolutely makes sense to look at that from the restorative standpoint. And something that I'm doing now with the restorative docs is what I ask you to do is give me a wax up of where you want the crown to be. And then I will decide surgically where that implant needs to go to best support that. That gives me a lot of information rather than asking you to make a surgical set, and it's significantly cheaper. Wax up on a stone model, what, 50, 60, 40 bucks?
Yeah, it doesn't matter.
And then I take that, and that shows me exactly what restoration needs to be, really in a volumetric standpoint. Because when the lab makes the varied types of stents that we get, including ones that are sucked down, type that you basically see for a bleaching tray, when you're trying to, I'm pointing at the screen right now, you're expecting that the hole is here and you think you're just going to drill press that. This is not even exaggerated, but that lingual plate, when I was at Columbus, in 1 year we had 3 patients come in intubated, a tube from their mouth into their lung that was placed by oral surgeons out in the field where the drill was done, the patient bled sublingually, and they had the skill set to place the tube into that patient's lung. When we took a CT, there was no room for air exchange between the soft tissue and that tube. Meaning that if that patient bled out sublingually without that person having the skill set to put a tube in that person's lung, that person would have died, regardless of who was trying to do CPR on them, because they would not have had an airway in order to support respirations. So sublingual bleeds much, much more than, oh geez, I perforated out of the buccal plate and I need to graft this case, is a significant life-threatening situation that really needs to be evaluated. You can palpate this and do that very easily, but it's a very, very crucial step that has to be taken into effect. And when you have a stone model and they're putting a surgical guide on, there is no value into where that lingual concavity is because the stone has already filled that. And again, as Marshall said, a lab tech is making that device, and it may not even be the lead lab tech, they're just doing their suck down and putting the rod in there. And there's a very amount of error rate that's there, but really anatomically it's huge. So the best information I can get from you is where does the wax tip need to go, where does your restoration need to go, and then I can plan the rest of the surgery.
Exactly.
And that makes sense. Yeah, well,
The other thing is, like you were saying, is to do the wax up. Y'all are taking and scanning the model with the wax up and incorporating it into the CBCP so he knows exactly, and may not use a guide, but he knows exactly where he's going.
you guys are taking my next slides. And shots were there flashing me the 5-minute sign. This is pressure all of a sudden. Okay, so how to plan it. The real way to plan it, the correct, which these smart guys already know. You start with the result, which is what Steve was saying. The lab knows the result. You start with what you want to end with. I've heard crown down. You design your implant crown down. So you start with the crown. There it is. Then you place the implant virtually on software. Then you know your abutment type. And then if it makes sense, then you order the guide if you need it. If you don't, at least you know this is going to be easy. So what's it look like? You can virtually create crowns if you want to and move them around. We normally scan patients in occlusion so we can have a better representation of what the crown should be. Then we can see the implants and move them back and forth, longer, shorter. We can position them and measure everything out, knowing what our abutment type will be, where our crowns are. And again, as you saw, and Chris is totally right, it's a simulated, fake, unfilled unit. I look at it as comparative. Red's bad, yellow's okay, green's great. So you can get an idea of what type of bone you're going into. Basically, you're going into wood, mud, or sand. And so this will tell you. And now, when you're looking at more complex cases, you can design this. Now, we could virtually place the crowns, but again, we're guessing. Wouldn't it be nice to superimpose a lab case on here? Superimpose a wax up? And so we look at these and say, this one's pretty good. That's pretty good. Well, actually, do I really want that abutment right on my incisal edge, or do I want to move this back? So the ability to superimpose is what we're talking about. And yes, we do that all the time. We do about a guide a day, so we're used to this. And anyone doing guides is used to it. The nice thing is, you can take the software, you can take a look, and say, what's it look like in 3D? Just, can I even do an implant? Does it even make sense? Is it even possible? We're going to look at something crazy like a block graft just to get it ready. Then you plan it out in the software, and then if need be, you say, okay, let's get a guide. So that's everything. Everything else is my quick question thing, just to end. We started in a world, we all came in this world without all these things. You'd be very hard-pressed to pry anyone's cell phone or TV. No one's going to 1-hour photo anymore. Who doesn't use email and everything else? And in the dental world, just like the real world, it's not flat. So, with Google you can get anything. So, we're not flat. You can't treat it as flat with a PAN or PA for a lot of things. So, that's us. I'm here with my business partner, Robert. He's way more polite and quiet and smarter than I am. But we'll be here all day. And any questions about what we do, please let us know. Any questions about CT, radiation, guides, anything else? As you can tell, I like to talk and answer questions, so just find me. And with that, I'll stop getting the warning light. I'll jump off.